about time for us to study the complement system and learn the most important issues that are showing up on your exam. The first and foremost questions are, what are the complements and what organ makes them? Of course, if you recall, I have said it over and over and over again that if you are at doubt and you don't know what organ makes any specific substance, you can always guess liver as your last resort. And for most part, you may be correct. You have to know, of course, the exception to this big generalization. Complements are glycoproteins made by the liver. They are made in pro form. The pro form of the complements are inactive. They are secreted into the blood and they will get activated, as we're going to see shortly, in the blood. After activation, complements enhance the ability of the innate immune cells to defend our bodies. Note that complements are also produced by tissue macrophages, monocytes, and epithelial cells of the genitourinary tract and gastrointestinal tract. What are the major functions of complements? Opsonization means that they enhance phagocytosis of the antigens. C3b by far has the most important opsonizing activity, followed by the next number, that is C4b, as we're going to see shortly. Chemotaxis. Complements attract the macrophages and neutrophils to the site of action, to where the bacteria is located. They cause cell lysis because they cause rupture of the membranes of foreign cells. We're going to be talking about the MAC complex shortly. They cause agglutination. They cluster and bind together pathogens and they cause agglutination. What are the only three complement pathways? These are alternative lectin, which is also known as Mannose-Binding lectin, and the classic complement pathways. Let's look at the general picture of the classic pathway. Classic pathway starts with binding of antigen and antibody, and remember, the antibodies, or the only two antibodies that can initiate the classic pathway, or they can bind practically the complements, are going to be the IgM and IgG. Remember the mnemonic that I said earlier. GM makes classic for classic pathway, classic cars. So after this association of antigen and antibody, complement 1, which is already produced by the liver and is in the blood, is going to get activated. This is just a summary to orient you again. Activated 1 activates complement 4. Activated complement 4 activates complement 2. So just remember, we don't go from complement 1 to 2, we go to 4 and then to 2, and in the classic pathway we bypass the complement 3 up to this point. Now here is the deal, that activated complement 2 is gonna cause formation of C4b2b complex. This complex, C4b2b, is also known as C3 convertase. C3 convertase will activate C3. So we're going to get activated C3 complement. So activated C2 and activated C3, both of them, activate complements 5, 6, 7, 8, and 9, and these are collectively known as the MAC complex. So we activate all of these complements almost together, however sequentially, from C5 to C9. And this is essentially the initiation of the MAC complex, or membrane attack complex. From a different angle, activated C2 causes formation of C4B2B complex. Remember this complex. This is also known as C3 convertase. So this is your famous C3 convertase. So as the name implies, C3 convertase activates complement 3. And complement 3 can also activate the MAC complements. Again, MAC complements that are C5 through C9. Now that we made activated MAC complex, this complex has lytic power and attacks cellular membrane of pathogens, mediates both pathogenesis and prevention of immune complex diseases. And I'm showing also in this diagram the alternate pathway, and I'm showing a gram-negative bug, and it has that lipopolysaccharide capsule or cover around it, LPS. The alternate pathway is going to be activated on the bacteria when C3 contacts the lipopolysaccharides of the bacteria. This is a very quick pathway. It doesn't need to sequentially walk through C1, C4, C2. It just, the moment that interaction happens between C3 and the surface of the pathogens, you get activation of C3 and you activate the MAC complex on the very same bacteria that C3 has joined to it. So these are the two major pathways that we're going to be discussing. In the box that I have here, I want to add just a short note for you that quite often by activation of these complexes, we mean that we split them into two units. For instance, when complement 1 is activated, it breaks into two units, complement 1A and complement 1B unit. For now, remember the bigger size component is the B component. B for bound, because it's going to get bound and stays, at the site of action. The fragment A, which is smaller, remember A for away, goes into blood and plays other roles. For instance, it acts like a cytokine to attract other cells into the site of action, or may cause anaphylaxis reaction, things of that nature. But the major part of these activated complements, after they break into A and B counterparts, is the component B, which is bigger and stays attached to the bacteria or to the site of action. It doesn't go away. So which of the three pathways is by far the most primal system? Actually, some students think this should be the classic pathway because of the name classic. However, this is not true. The alternate pathway is by far more primal. This is the one that goes back to the beginning of the history of the higher vertebrates. However, interestingly, in the history of medicine, we first defined and identified the classic pathway. And this has been a reason for confusion of students. The lower organisms with no adaptive system still have complements, and in particular the C3. So between the two, the most important that has the survival value for the organisms is the alternate. So C3 made by the liver, it circulates in the blood. It can get deposited on the pathogen's surface, and it causes a chain of reaction leading to microbial lysis. This is the important issue related to the alternate pathway. So what is by far the most abundant complement in the body? The most abundant, quantitatively abundant complement is complement 3. How does the alternative pathway get activated? C3, as we said earlier, is always in the blood. Liver has made it, has dumped it into the blood. When it confronts the lipopolysaccharides of bacterial cell, it combines with the factor B, another factor in the blood. Just remember the name, factor B. I understand these B's, so many letter B's, confuse students, but this is another factor that I want you to remember. This factor is always present in the blood. The complex of C3 factor B attaches to another factor. To make it more complex for medical students, this factor is factor D, another blood factor. Now the complex of C3, factor B, factor D then acts as a C3 convertase, or if you wish, C3 stimulator, and cleaves C3 into these two important fragments, fragment A and B. This in turn, and in particular, as you can tell, fragment B is the one who plays the role, activates the MAC complex, and MAC complex causes lysis of the bacteria. Which of the three pathways is closely associated with the adaptive system? Classic pathway. It is antibody activated, and the Fc portion of the antibody can activate complements. This happens when the antibody is bound to the pathogens, and I've shown pictures to you earlier, and we have already discussed this. The other pathways are more related to the innate system and do not require contribution from the antibodies. So the lectin system and alternate system do not require contribution of the antibodies. The only two antibodies that we are talking about are IgG and IgM. So let's first and foremost look at the classic pathway in more detail. This pathway engages three major complements, 1, 2, and 4. The pathway is initiated by antibody-antigen complexes. The antibodies are IgM and IgG, and they're binding to complement 1. The pathway results in formation of C3 convertase, which splits C3 into two fragments. The larger and bigger and more important fragment from the standpoint of the destruction of the bacteria, because C3 binds to the surface of the microbial pathogens and opsonizes them, and the smaller fragment goes away, A for away, and activates mast cells and induces release of vasoactive amines, and A for anaphylaxis also, because it causes anaphylactic reactions via involvement of the mast cells. This pathway is antibody activated, and the Fc part of the antibodies, more specifically IgM and IgG, can activate the complement C1. This happens when antibody is bound to the pathogen. Note that macrophages also have Fc receptors, and they are able to attach to the Fc segment of the antibodies that are bound to the pathogens. IgM and IgG are the only two antibodies that can activate the classic system. These two antibodies are also the major antibodies in the blood and tissues. Remember, GM makes classic cars, IgM and IgG for the classic pathway. Then I get to lectin pathway, Mannose-Binding lectin pathway. This pathway, like alternate pathway, is not dependent on antibodies. An adaptive system is the least known of the three pathways. It is activated by binding of Mannose-Binding lectin, MBL, to mannose residues on the pathogen surface. This activates the MBL, Mannose-Binding lectin, associated serine proteases. There are two major proteases or enzymes. One is MASP1, which stands for Mannose-Binding lectin for M, A for associated, S for serine, and P for protease. So as you can tell, so far we have identified two of these proteases, MASP1 and 2, which in turn they activate C4 and C2 to form the C3 convertase. Lectins are carbohydrate binding proteins. They are highly specific for sugars, and they should not be confused with glycoproteins. Note that lectins are abundant in raw legumes and grains. Additionally, some bacteria have mannose-rich lipopolysaccharides. Macroorganisms such as Salmonella, Listeria, Neisseria, Leishmania are all shown to bind lectin. It is obvious that continual activity of the complement cascade not only depletes the factors or complements but also aggravates inflammation. The question is, how is the complement cascade inhibited? There are several regulatory proteins associated with cell membrane that inactivate the activated complements. To name a few, decay accelerating factor, DAF. What does this do? It inactivates C4b and C3b fragments. Another noteworthy one is C1 esterase. What does this do? It inhibits the classic pathway at the onset of the classic pathway. Complement 3 is always present in the blood and may potentially activate the MAC complex in normal cells and tissues. Why is this issue usually not seen under normal conditions? Normal cells have this must-know compound, the decay accelerating factor, DAF, which is also known as CD55. DAF is on the surface of practically every cell of the body and is more abundant also in bone marrow derivative cells, as we're going to see shortly. So normal cells have DAF, and DAF is the one that inactivates C4b and C3b fragments. So DAF inactivates activated C4 and activated C3, if you wish. So what major diseases are shown to be associated with complement deficiency or complement regulatory dysfunctions? Recurrent infections by encapsulated bugs such as Neisseria, Haemophilus influenzae, and Streptococcus pneumoniae are the top 3 in the list. But there are a lot more other encapsulated bugs in the list. The list can go on further. For instance, you can include E. coli and, let's say, Klebsiella also into the mix. The other important association, a nasty association, is hereditary angioedema. The other must-know association is going to be paroxysmal nocturnal hemoglobinuria. And also some of these chronic conditions such as rheumatoid arthritis and systemic locus. What is the most common complement deficiency? Most common from a standpoint of genetically being most common, not clinically being more commonly tested one. This is complement 2 deficiency. This is by far the most common complement deficiency in the Caucasian population. But clinically, and for the sake of the exam, complement 3 is by far the most important one, clinically speaking. So what is the name of a disease that results from decay accelerating factor malfunction? This is paroxysmal nocturnal hemoglobinuria, or PNH. What is the mechanism of PNH? Bodily cells have a membrane protein, which is glycosyl phosphatidylinositol, or GPI. GPI anchors DAF molecules to the cells. If there is an acquired defect in the anchor, in the GPI, the DAF or CD55 cannot attach to the bone marrow derived cells, in particular the red blood cells, platelets, and neutrophils. I'm showing DAF as a shield in this diagram to show you the defense mechanism that DAF plays in defending the bone marrow derivative cells, and I'm showing in this diagram a neutrophil against the damages that activated complements. For instance, I'm showing the C3 convertase in this diagram for you. DAF is a safeguard against lytic effects of complements on these cells because it inhibits C3 convertase of the alternate pathway. Hence, red blood cells and platelets of these patients will be subjected to lytic effects of the MAC complex. Of course, the white blood cells may also be a target. Just to repeat the concept that we have covered before, C3 convertase is formed when fragment B of C3 binds to B factor on the cells and causes cleavage and conversion of C3 to C3b. And C3b, of course, B stays bound, and also C3a that causes anaphylactic reaction. C3b is an opsonizer and also makes C5 convertase that causes MAC formation that damages the red blood cells or white blood cells or platelets in the absence of DAF. So DAF is defense, if you wish. DAF, D stands for defense, A stands for against, F, furious, or against foes, if you wish. Or you can say DAF is defense against furious MAC. But anyhow, this gives you a good mnemonic to remember the role of DAF. What are some of the clinical findings of paroxysmal nocturnal hemoglobinuria? Well, hemolysis of the red blood cells causes hemoglobinemia and hemoglobinuria, and as a result, anemia. So these patients lack energy. I want you to know that nocturnal is a misnomer as the condition is chronic. However, if you're interested why we call it nocturnal, because during the night people sleep and usually don't use the bathroom as often, so the urine may get concentrated. And in the concentrated urine, if we have hemoglobin there, so that causes redness of the urine in early morning hours. This is the explanation that I personally like and many others like. However, in some books and literature, you may hear scholars talking about nocturnal respiratory acidosis that causes this issue. And again, this may happen in patients with sleep apnea. This explanation, the second explanation, I personally don't like, but I just wanted to talk about it in case you see it in some of the textbooks or in some of the writings. Degradation of the platelets causes thrombosis. This may cause potentially infarction of some important organs of the body. Finally, damage to the white blood cells leads to infection and fever. So, if I want to tell you what are the major symptoms that bring patients to you quite often for the first time diagnosis, are going to be multiple infections and fever and lack of energy and anemia. So what complement deficiency is associated with GN? GN stands for glomerulonephritis. This is complement 3. What is common bug that surfaces in various complement deficiencies? The most common association is Neisseria. What is the unique complement deficiency found in 70 to 75% of membranoproliferative glomerulonephritis patients, MPGN patients? Again, this is complement 3. We do believe that this deficiency is mostly attributed to overconsumption of C3 in the nephrons. Why do patients with complement 1 esterase inhibitor deficiency get serious laryngeal and facial swellings? C1 inhibitor, another name for it is C1 esterase inhibitor. Deficiency of this is an autosomal dominant defect that causes hereditary angioedema. It is associated with widespread edema and severe laryngeal and facial swelling. The average age of the diagnosis is after age 40. Remember, we don't have much tissues in the neck, we don't have much tissues on our face. For that reason, the swelling, at least visually, is more prominent on the face and on the neck, because you can theoretically get the edema everywhere in the body. Failure to degrade C1 causes excessive activation of classic complement pathway and ongoing C3A, C5A formation. A for away, if you remember. These two components are potent anaphylotoxins, and when they go into the vessels away from the site of action on the bacteria, they cause the vessels to get extremely leaky, and they recruit neutrophils to tissues, and they cause mast cell degranulation. This results in edema of all tissues. It may jeopardize the breathing functions and may cause asphyxiation. That is essentially the most troublesome issue for the patients. C1 esterase inhibitor is a protease inhibitor that is mainly produced by the liver and to some extent by activated monocytes. This is also labeled as an acute phase protein and typically circulates in the blood at low levels in normal individuals, but its levels may greatly increase in all individuals during inflammation. What is the treatment for acute attacks of facial edema? Of course, these acute attacks can be potentially deadly, so it's a good time to talk about management a little. Antihistamines and epinephrine are the first line medications for anaphylactic reaction and responses in the patients. The other modality that we use is purified C1 inhibitor, C1-inhibitor, INH. This is a protease inhibitor and is used for prophylaxis of acute attacks in individuals who get recurrent attacks. The other medication is Berinert, which is a human plasma-derived, purified, and pasteurized concentrate of protein C1 esterase inhibitor. It is used for treatment of acute abdominal and facial angioedema attacks. Actually, as you can see, there is also another painful consequence of C1 esterase deficiency, and that one is acute abdominal pain, which is extremely painful. So, what medication causes angioedema? There are some medications that also may cause angioedema formation. These are going to be the ACE inhibitors. Why do they do this? Because of bradykinin formation. And it's the bradykinin that causes anaphylactic reaction. What is the difference between urticaria, which is hives, and angioedema? Because as you can tell, the angioedema and urticaria, they have a similar pathophysiology. So it's a good question that may come to your mind how you have to differentiate the two from each other. Angioedema and urticaria both have similar findings and similar pathophysiology. Angioedema is the rapid edema of the dermis, subcutaneous tissues, mucosa, and submucosal tissues. In contrast, urticaria or hives occurs on the upper dermis. So urticaria on the surface, angioedema below the surface. Angioedema is classified as either hereditary or acquired. Which of the two forms is often not responsive to epinephrine administration? Actually, this is the acquired version, acquired angioedema. Acquired results from allergy, or it may occur as a side effect to ACE inhibitors. It is characterized by repetitive episodes of swelling, frequently of the face, lips, tongue, limbs, and genitals. Edema of the GI mucosa typically leads to severe abdominal pain. Edema in the upper respiratory tract, likewise hereditary angioedema, may be life-threatening. What are opsonines? These are B complement fragments, C3b and C4b. They adhere, remember B for the body, for the bulk. They stay attached, they adhere to microorganisms, and they promote leukocytic chemotaxis, phagocytosis, and macrophage activation. What are anaphylatoxins? These are fragment A of, in particular, C3 and C5, and A for anaphylaxis. These are released into surrounding tissues next to the site of action when we have activated complement 3, and they bind to receptors on mast cells and basophils, and they cause degranulation and release of vasoactive cytokines such as histamine and bradykinin. So C3b, C4b for bonbon. And remember that I've shown earlier that they stay on the body of the bacteria, and bonbon in French means candy. A candy which is coated by chocolate. This C3b and C4b, they cause chemotaxis in the neutrophils and macrophages, and they get attracted to these tasty bonbons. And of course, C3 and C5a, A for anaphylaxis. So B for bonbon and A for anaphylaxis.